evening to tune in to our webinar on COVID-19, Perspectives from Theology and Public Health. My name is John Shevland, and I'm a member of the Religious Studies Department. And on behalf of its chair, Dr. Kevin McCrudden, it's my pleasure to say a few words about this lecture series and to introduce our panel of speakers. I begin first with a land acknowledgement. I'm speaking to you from the campus of Gonzaga University, which resides on the colonized land of the Spokane tribe and the connected tribes of this region, who were made to suffer genocide and the continuing scourge of white supremacy. We wish to respect these people, past and present, and to seek ever new and mindful ways of respecting their land, water, and air. Wherever you may be sitting today, consider researching the original peoples of your region, learn their history, establish relationships with them, and support tribal sovereignty. Doing so is one way to reject generations of erasure and to amplify Indigenous voices. You can learn about whose land you are on by visiting the website native-land.ca, native-land.ca. Each semester, the Flannery Lecture is made possible by the Flannery Endowment, established all the way back in 1973 by Milo and Maud Flannery to promote the study of Catholic theology at Gonzaga University. Tonight, we dip into that stream of support 47 years later, and it's a wonderful gift to stand in the tradition and to witness the variety of events and speakers their generosity has made possible. We have a member of the Flannery family watching from the comfort of his home this evening, Michael Flannery, and his husband, Dean Lynch. They have faithfully attended these lectures over many years. Thanks to both of them for the many ways they support Gonzaga University through this lecture series and beyond. Thanks also for their friendship. Thank you, Michael and Dean, for your friendship over the years. And thanks also for the gift of your great aunt and great uncle, without whom we would not be together, albeit via Zoom. We would not be together this evening. I wish to thank very briefly also Jackie Fulton and Jackie Triber. Jackie Fulton in the Religious Studies Department is a wonder and a great help in the organization of these events, and Jackie Triber for her help with technology. Tonight, we will hear first from our speaker, Dr. Bob Lutz of Spokane Regional Health District, who will speak on the public health implications of COVID-19. Then we will hear from two theologians. Dr. Shawnee Daniels-Sykes will speak to us from Milwaukee, Wisconsin, where she teaches at Mount Mary University. Then Dr. Teresia Hinga will speak to us about the African and Kenyan experience of COVID-19, and she will be joining us from Santa Clara, California, where she teaches theology at Santa Clara University. Each speaker will speak for about 15 to 20 minutes, after which they will together as a panel engage each other and engage you, the audience, in conversation. Audience members, please know that you are welcome to write questions into the webinar's Q&A tab, and we will do our best to respond. So Dr. Bob Lutz is a graduate of Temple Medical School and has spent 4 years in the US Navy before completing a residency in family medicine and a fellowship in sports medicine at Bayfront Medical Center in St. Petersburg, Florida. He also completed a fellowship in integrative medicine at the University of Arizona, where he also received his master's degree in public health. He served on the Spokane Regional Board of Health for 8 years prior to becoming the health officer for Spokane County in 2017 and Asotin County in 2018. Also in 2018, he was appointed to the Washington State Board of Health, representing the state's health officers. He holds adjunct faculty appointments at the Elson S. Floyd College of Medicine and the University of Washington School of Medicine here in Spokane. Bob, thanks so much for joining us this evening, taking time out of your extraordinarily busy schedule. The floor is yours.
Thank you, John. Can you hear me okay?
Hear you great.
Great, thank you. Well, it's truly a pleasure and honor to be here with you this evening and to serving as, if you will, this anchor for my two very esteemed colleagues who will be talking next about sort of the theological implications of COVID-19. Health begins where we live, learn, work, play, and pray. This statement from the Vulnerable Populations Portfolio in 2010 from the Robert Wood Johnson's Foundation identified factors outside of the healthcare system that impacted the health or lack thereof of the American population. In an article in the April 2016 issue of the American Public Health Association's journal, Dr. Karen DeSalvo, Acting Assistant Secretary for Health at the U.S. Department of Health and Human Services, along with fellow officials from the Department of Health and Human Services and the Centers for Disease Control and Prevention, argued the nation's disease burden was increasingly attributable to behaviors shaped by social and environmental determinants, leading to the statement, your zip code is more important to your health than your genetic code. These two references from the past decade reflect years of research that have identified how community conditions impact the health and well-being of their members. Far more than healthcare, our health is influenced by the level of our education, our jobs, our income, our environment, as well as how we are perceived and treated by society. Unfortunately, because we are not all starting from the same place, we do not all have the same opportunities to achieve optimal health. We emphasize the importance of improving access to medical care. More than 20 million Americans gained health insurance coverage since the ACA was enacted in 2010. The ACA's coverage gains occurred across all income levels and among both children and adults, and disparities in coverage between races and ethnicities narrowed. To date, 39 states, including the Washington, D.C., have adopted the Medicaid expansion, and 12 states have not adopted the expansion under the ACA, with 12.7 million people covered through the expansion. Medicaid expansion has led to better access to care and health outcomes for low-income individuals and their families across the country. A large body of evidence shows that Medicaid expansion increases utilization of health services and diagnosis and treatment of health conditions. Beyond health outcomes, evidence points to improved financial well-being in Medicaid expansion states, including reductions in medical debt and improved satisfaction with one's current financial situation. A study that assessed eviction rates in California found that Medicaid expansion was associated with improving housing stability. And evidence shows that Medicaid expansion saves lives. According to a 2019 study, Medicaid expansion was associated with 19,200 fewer deaths among older low-income adults from 2013 through 2017. 15,600 preventable deaths occurred in states that did not expand Medicaid, however. Unfortunately, healthcare and public health, what I would argue are inalienable rights, have been the targets of politicization. Of those states that have not pursued Medicaid expansion, 7 are in the Southeast, as well as Texas. Of these 8 states, 5 have the notoriety of being in the, quote, top 10 of states with the most COVID-19 cases. Texas and Florida have the 2nd and 4th greatest number of deaths from COVID-19, respectively. The Affordable Care Act's future continues to be uncertain, as the law's constitutionality will once again be considered by the U.S. Supreme Court in California versus Texas 1, known as Texas versus U.S. in the lower courts. Oral arguments are scheduled for Tuesday, November 10th. This ongoing litigation challenges the ACA's minimal essential coverage provision, aka the individual mandate, and raises questions about the entire law's survival. The current administration is largely siding with Texas, while 17 other states, led by California and including Oregon and Washington, are defending the ACA in court. If all or most of the law is ultimately struck down, it will have complex and far-reaching consequences for the nation's healthcare system, affecting nearly everyone in some way, to include possibly eliminating protections for people with pre-existing conditions, subsidies to make individual healthcare insurance more affordable, expanded eligibility for Medicaid, coverage of young adults up to age 26 under their parents' insurance policies, and coverage of preventive care with no patient cost sharing. But while not to underemphasize the importance of healthcare, consider it's been estimated 8 times more lives can be saved with education than with medical advances. This recognizes the fundamental role of education to our health. The study entitled Giving Everyone the Health of the Educated, an examination of whether social changes would save more lives in medical advances, published in the American Journal of Public Health, found that between 1996 and 2002, medical advances averted at most approximately 179,000 lives. Conversely, correcting disparities in education-associated mortality rates would have saved more than 1.3 million lives during the same period. Health is positively associated with education. Health improves as one's education attainment increases. Data from the National Longitudinal Mortality Study notes people with higher education live 5 to 7 years longer than those who did not finish high school. Infant mortality rates decrease when a mother has a college education. Conversely, infant mortality rates increase when babies are born into poor families, which often equates with lower levels of education. Better educated people have more opportunities to make healthier decisions. They have the money and access necessary to buy and eat healthier foods, are more likely to be familiar with the dangers of tobacco and alcohol use, and as such, use them less. So we know through research and practice that people with more education generally lead longer, healthier lives and are more involved in community activities, thereby providing them a voice in decisions that affect them and their entire community. This linkage of health to better education, one of what we call social determinants or factors affecting health, echoes my opening statement. Health begins where we live, learn, work, play, and pray. While this doesn't mean we shouldn't ensure everyone has access to health care, it does indicate our nation's health, and especially those whose lives are marginalized because of the color of their skin or where they hail from, could be positively impacted by societal investment. Health equity is defined as all people having the opportunity to attain their full health potential, regardless of social position, race, ethnicity, education, gender identity, sexual orientation, disability, or other socially determined circumstances. Unfortunately, structural racism undergirds American society. This country was built on the backs of slave labor and on the land of indigenous peoples. Marginalized or vulnerable refers to the processes and conditions by which specific populations are impacted by structural, avoidable, and unnecessary inequities, which result in disproportionate illness and hardship. Historical and systemic barriers were designed to exclude and erase certain populations. Privileges and burdens are distributed unevenly across society, such that marginalized communities experience the worst impacts of every crisis. Due to their marginal positions in American society in terms of both power and resources, these populations face unequal, unfair, and preventable deficits in their health status. These differences in health status are unfair, preventable, and lead to what Nancy Krieger has labeled, quote, embodied inequality, end quote. This inequality is based on socioeconomic position, race, ethnicity, nationality, nativity, immigration and citizen status, age, and gender. Discrimination and social injustice lead to poor health outcomes that are multi-generational, beginning before birth and extending throughout the life course. The coronavirus pandemic illustrates adverse impacts of this crisis, including increased risk of disease, hospitalization, and death, and the economic impacts of this crisis have disproportionately affected vulnerable communities. In August of this past year, the Washington State Department of Health released a report that showed the significant disproportionate impacts COVID-19 has had on Washington's community of color. Native Hawaiian or other Pacific Islander people and Hispanic people have age-adjusted rates approximately 7 times higher relative to whites. Hospitalizations are 8 times higher for Hispanics and 12 times higher for Native Hawaiian or other Pacific Islanders relative to whites. Hospitalizations and case rates for Black people are approximately 3 times higher than that of whites. And American Indian and Alaska Native case rates are 2.5 times higher, and hospitalization rates are 3 times higher. Among COVID-19 deaths, we see similar trends. But these findings are not unique to Washington State. The title of a viewpoint in the Journal of the American Medical Association entitled Failing Another National Stress Test on Health Disparities noted infection and death rates in 131 predominantly Black counties across the US are threefold higher and sixfold higher, respectively, than the overall US rates. Maybe not surprisingly, many of these are in those Southeast states that declined to pursue Medicaid expansion. In late May, the Navajo Nation was reported to have more than 2,400 infections per capita, a rate far exceeding that of New York and New Jersey, the two states that served as the epicenters of the pandemic in the United States. Nationally, almost 1 in 5 deaths of Native Americans and Hispanics are caused by COVID-19. Where and how people of color and other marginalized groups live matters, as race oftentimes determines home. In The Color of Law, a forgotten history of how our government segregated America, Richard Rothstein, a research associate at the Economic Policy Institute, argues from the first segregated public housing projects of President Franklin Roosevelt's New Deal to the 1949 Housing Act that encouraged white movements to the suburbs, to unconstitutional racial zoning ordinances enacted by city governments. The current state of the American city is the direct result of unconstitutional, state-sanctioned racial discrimination. Differences in health exist in communities with unstable housing, low income, unsafe neighborhoods, and substandard education. Long-standing societal and institutional policies and practices lead to health inequities. These communities continue to feel the reverberations of the Great Recession from 2009. They face greater financial difficulties than their white counterparts. The coronavirus pandemic has compounded and intensified these struggles. A recent national poll by NPR, the Robert Wood Johnson Foundation, and the Harvard School of Public Health found that among households participating in the poll, the pandemic's financial impacts are severe and include difficulties paying for housing, utilities or car payments, affordable medical care, paying credit cards or other debt, affording food, and depleting savings. For Black respondents, 40% are struggling to pay rent or mortgage. 43% say they have trouble paying utilities. For Latino households, 46% are struggling to pay mortgage or rent. About a third of Black and Latino respondents who lost household incomes are struggling to pay for food. 72% of Latino and 55% of American Indian respondents say their households are facing significant financial problems. The burden of disease among vulnerable and marginalized communities is not unique to this pandemic, unfortunately. Disparities in heart disease, diabetes, and their associated risk factors have their origins in the legacy of discrimination, racial injustice, and inequities in social opportunity. The COVID-19 pandemic has unfortunately highlighted the connections between these inequities of health, society, and the economy. A society with long-standing inequities make people more susceptible to contracting and dying of this infection. Decades of multi-generational chronic stress and trauma have taken their toll. Historical and systemic barriers that have been maintained to exclude and marginalize populations have perpetuated the uneven distribution of power and privilege across our society, leading to these communities experiencing the worst impacts of every crisis, be it a pandemic, a natural disaster, or an economic downturn. Pope Leo XIII said On the Condition of Labor, a basic moral test is how our most vulnerable members are faring. In a society marred by deepening divisions between rich and poor, our tradition recalls the story of the Last Judgment and instructs us to put the needs of the poor and vulnerable first. Still, when there is a question of defending the rights of individuals, the poor and badly off have a claim to a special consideration. The richer class have many ways of shielding themselves and stand less in need of help from the state, whereas the mass of the poor have no resources of their own to fall back upon and must chiefly depend upon the assistance of the state. The COVID-19 pandemic has yet again demonstrated a society that does not respect the rights of all of its citizens equally will see those who are most vulnerable suffer unequally. Now is not the time to accept the status quo. As individuals and more broadly as a community dedicated to respecting the dignity of every person, irrespective of the color of their skin, their position in society, or where they live, learn, work, play, and pray, we have a responsibility to care for the least of our community members by not just acknowledging the unjust systems that have perpetuated these disparities, but by actively dismantling them. Only by doing so, we will be able to provide every member of our society the opportunity to achieve her or his potential, which for many has been intentionally denied. Truly, I tell you, whatever you did for one of the least of my brothers and sisters of mine, you did for me. Matthew 25:40. Thank you.
Thanks so much, Bob, for that challenging presentation. Just a quick reminder to the audience, you are welcome to, along the way, pose questions, to write your questions in the Q&A tab that is at the bottom of your Zoom screen there. Thank you again, Bob. We'll move on to Dr. Shawnee M. Daniels-Sykes. Dr. Daniels-Sykes is a registered nurse and a theologian. She received her doctorate in theological ethics and bioethics from Marquette University and serves as professor of theology at Mount Mary University in Milwaukee. Her research and writing include the beginning, middle, and end of life issues, where she examines the intersectionality of racism, sexism, and classism. Her research and publications include the highly disproportionate rate of Black maternal mortality, a Black Catholic liberation ethics as it relates to the history of racism in the US, healthcare and research institutions, death shrines that are erected after gun violent homicides in the city of Milwaukee and beyond, among other interests. She is a member of the CTSA, the Catholic Theological Society of America, the Society of Christian Ethics, the Black Catholic Symposium, and the Catholic Theological Ethics in the World Church Organization. Dr. Daniels-Sykes, thanks so much for being with us this evening, and the floor is yours.
Thank you, John, for inviting me to participate in this very important conversation. Thank you for the Flannery family too, for just having the wisdom to continue to have Catholic dialogues in a lecture format such as this. As I share my reflections tonight on perspectives from public health and theology, COVID-19, I'm going to also undergird my reflections by looking at rights theory as it undergirds USA liberal democracy. I'll talk briefly about key principles of Catholic social teaching and how these major principles and ways of thinking are so important for our conversation tonight in our lecture. So as I paid attention to the early news reporting of the pandemic, I was keenly aware of the news weekly reports of the effects of the virus on the elderly population. And this went on for about 2 to 3 months. Colleagues and I wondered when other vulnerable populations would be investigated in light of the negative effects of the pandemic too. The wonderment is especially because of the longitudinal history of health disparities in this country that adversely impact communities of color and rural communities. And Bob gave a really beautiful overview of what that looks like. The highly disproportionate rates of medically uninsured and underinsured, those who have limited access to healthcare due to a lack of transportation and communication and inabilities to navigate the medical system, family members' suspicions and mistrust, those with chronic conditions such as cancer and diabetes and hypertension, economic poverty, systemic racism, among others. Indeed, COVID-19 has unearthed and illuminated what I'm going to be talking a little bit more about is a cycle of prejudice and oppression, which includes what Iris Marion Young named the 5 faces of oppression. They include exploitation. And we can see examples of exploitation from our interest in news reporting of the essential workers and frontline workers, and those who could not shelter in place will work to help to prevent the spread of COVID-19 either to themselves or to others. They still had to go to work. Young also talks about the marginalized or marginalization as part of the 5 phases of oppression. In this country, a large portion of the population is marginal, and Bob basically illuminated that in his remarks. As aforementioned, the elderly, young people, especially Black and Latinx, single moms and their children, people are homeless, the unemployed and medically uninsured and underinsured, those who are physically and mentally challenged. A third phase of oppression is powerlessness. And this includes those who lack the authority, the status, and a sense of self that professionals or those in power tend to have to make decisions about how to stop the spread of the virus. And so you have people who are in power differentials. The powerful have and the powerless don't have. And then we have this phenomena that Iris Marion Young calls a culture of imperialism. And this is the universalization of a dominant group's experience and culture, and its establishment as the norm. Here we can argue that compared to the overall total population in the US, which is approximately 320 million people, we can look at that in light of the number of cases. It's approximately 8.5 COVID cases, and the number of deaths from COVID-19, approximately 225,000. Someone who is looking at this from a cultural imperialistic perspective basically would see those numbers and compare to the overall total USA population as minimal. The way that COVID-19 is considered encompasses a utilitarian thinking, which is a real important thing for us to remember in terms of what is over and undergirding this whole mentality in terms of, calling it a hoax or basically saying that it does not matter. We focus on the greatest good for the greatest number of people in this country. The majority rules. But I ask, as a theological ethicist and one who is concerned about the exploited, one who's concerned about the marginalized and powerless, how do they fall out of that utilitarian calculus, and what are we called to do about it? The fifth phase of oppression that Marion Young talks about is violence. For her, the oppression of violence consists not only in direct victimization, but in the daily knowledge of all members of oppressed groups that they are liable to violation solely on the count of their group identity. For example, these 3 news stories that were sponsored in USA Today recently on COVID-19, entitled, number 1, Housing Segregation Made New Jersey Ripe for the Pandemic. Number 2, Americans living in Cancer Alley suffer and die from high rates of COVID-19. And the third article from USA Today, America's history of racism was a pre-existing condition for COVID-19. I argue that these articles emphasize the notion of violence and how huge it is in the United States. To further illustrate the cycle of prejudice and oppression, I'm going to show you a cycle. So I'm going to share the screen. And let's see. Here's an illustration of the cycle of prejudice and oppression. And we can all say that we're born into a society, and let's say that we're talking about the United States of America. We're born into the United States of America. There's systematic training about various people, places where people live, income that people have, whether or not they're wealthy, whether or not they're poor, whether or not they're middle class. There's systematic training around that in terms of myths and stereotypes and misinformation and missing information and biased history. And that continues to be taught and reinforced by family and friends, schools, teachers, and books, religious institutions, the media, government, cultural standards. It's internalized. And eventually we believe that stereotypes and lies equal the truth, that human difference is negative, that conscious and unconscious beliefs and attitudes are internalized. Some groups are more valuable than others. White people are superior to people of color, or men are superior to women. This then results in behavior, prejudice behavior, oppressive behavior, behavior based in internalized oppression. And here we can draw on the issues around exploitation and marginalization and powerlessness, cultural imperialism, violence that Iris Marion Young talks about, that behavior. The societal messages don't make waves. Don't challenge the status quo. Just keep living your life. But as Christians and as Catholics, we are called to interrupt this cycle, even if it does cause confusion, hurt, anger, fear. There is a call for us to continue move towards dismantling and disrupting this cycle. We must learn the untruths, as we are trying to do with even with this lecture tonight. Replace with new attitudes and knowledge. Develop skills and take action. Otherwise, this cycle continues. The 5 faces of oppression continues. Another child or children are born, and that systematic training continues over and over and over again. And so one can see how prejudice and the 5 faces of oppression have become, what I argue, normative in our society. We live in a liberal democracy that is driven by negative rights or positive rights and social rights. Briefly and succinctly, negative rights or negative freedoms as a dominant ethos. Here, one does not have to pay attention to, nor can one be forced externally to pay attention to the plight of others. With negative rights or freedoms, arguably, there's a implied rugged individualism that is sustained, including the right to be morally indifferent, to even be morally blind. Essentially, life is all about me, myself, and I. Even the political debates about income taxes, about even wearing face masks and social distancing. For too many, for example, it's about me, myself, and I. Secondly, positive rights affirm the way that individuals commonly participate to maintain the good moral life via governance, public health, healthcare institutions, food industries, educational institutions, etc. It's important to note that negative rights continues to dominate, however, in our liberal democracy, maintaining the distinctions between the haves and the have-nots. Thirdly, social rights refers to the right to access healthcare, education, housing security, food, shelter, clothing, security. Yet, our negative rights make it difficult to guarantee equal and universal access to these aforementioned human resources or social goods. Hence, we must explore more deeply beyond these secular theories of modern rights that drive our liberal democracy. We must begin to illuminate and highlight what is deemed the Catholic Church's best kept secret is Catholic social teaching. Catholic social teaching, the Church's social doctrine, envelops not only negative rights, but positive rights and social rights. into what I argue and moves into a system in which I argue bends towards social justice and social equality. Underscored by biblical, social, and moral perspectives. Key principles of Catholic social teaching include, for example, human dignity. Human dignity is foundational. It basically claims, proclaims, declares that we are created in the image and likeness of God. And if that is the case, then we are brothers and sisters to one another. We are social beings called to be in right relationships. We speak then of community and the common good. We speak of global solidarity. We also speak of the constructive role of government, the preferential option for the poor, vulnerable, and marginalized, the promotion of peace, rights of the worker. Even with these principles, there is a balance presumed between personal responsibility and the concern for community. There's a presumed balance between individual or negative rights and the common good. Arguably, although there is a dire need for Catholic social teaching to be at the forefront of our public square in our liberal democracy, and even in light of COVID-19 and other issues that create racial and social unrest and dis-ease, our social teaching, I believe, is really underperforming. Our social teaching is really underperforming. We need to publicly proclaim that the Catholic Church has the best universal social teachings ever. These teachings must no longer be our best kept secrets. Instead, they must be employed to unlearn the untruths. They must be integrated with our new attitudes. They must be used to develop skills and engaged openly, honestly, and prudently as we take action. Thank you.
Thank you, Dr. Daniels-Sykes, for that gauntlet throwdown, the challenge that the social teaching of the church is really underperforming. A lot is captured in that one remark. So thank you. Our final speaker is Dr. Teresia Hinga. Dr. Hinga was born in Kenya and took her bachelor's degree from Kenyatta University in Nairobi, and she holds a master's degree from Nairobi University as well. She received a Ph.D. in religious studies and African Christianity from the University of Lancaster in England, and her teaching and research focus on women's issues in Africa, African religious history, and the ethics of globalization. She's the author of, and I just lost it right in front of me here. She's the author of a text called African Christian Feminist, The Enduring Search for What Matters. And she is a founding member of the Circle of Concerned African Women Theologians. She's also a member of the Black Catholic Symposium and of the Association for the Academic Study of Religion in Africa. So Teresia, the floor is yours. Thanks so much for being here as well from down the coast in Santa Clara, California. Please take it away. You're on mute. I muted you earlier. I apologize for that. Still on mute.
Yes. My technology is very kind of minimal.
You're good.
And for that reason, I've requested my daughter, and with your permission, to be on standby to help me at least the screen share part. Let me start by thanking Bob Lutz for anchoring this presentation very well with his essay and with his remarks earlier in the day. I want to also thank Gonzaga University for inviting me for this opportunity to share my reflections, which are for the most part tentative, because we are in the middle of this crisis. We haven't had time. It's a 6-month-old, very wicked problem that defies quick answers. And we are tentatively sending out feelers. What are the ethical ramifications of this phenomenon in our midst? So thank you very much for the opportunity. Thank you, Shawnee, for setting the stage. And I am touched by the fact that there's a lot of overlap. There's a continuity between what has been said already and what I'm going to say. I want to start where Bob left and remind ourselves that the place, the zip code, might be more of a determinant of one's health than the virus itself or the whatever biological issue, pandemic that we are facing. And so take that to heart as I consider the African place, the African space from which and to which I speak. I want also to pick up from Shawnee, the whole idea that myths can inform people's, and stereotypes can inform people's responses and interventions, leading to the disparities in health, in this case, but also disparities in other areas of social rights. And so I start by pointing out that Africa is responding to the COVID-19 pandemic against certain several historical experiences. Shawnee talked about the historical precedents that shape the current responses. One is the so-called myth of the dark continent. You probably have heard the thought that Africa is the dark continent. Now, this myth was created in the 19th century by European explorers. It's a young myth, a relatively young myth, by explorers, missionaries, and what I call social Darwinist anthropologists. And it was created and it became a rationale for colonizing Africa. Shawnee talked about colonization of the Native Americans as being preceded by this very thought that they don't matter. So Africa was also considered dark because it was allegedly immoral by default. And their lack of morals was because they lacked proper religion. For the Europeans, proper religion was Christianity. So morality that flows from religion was lacking in Africa. And hence, according to David Livingstone, one of the missionary explorers, they are violent people. They tend to bloodshed at their least provocation, and an instantiation of their violence and lack of ethics, according to David Livingstone, was that they participated in slavery. The way they twisted that whole slavery narrative to blame the Africans. I propose that this myth of the dark continent continues to haunt Africa even today and is shaping interventions regarding COVID-19 as it shaped interventions regarding HIV/AIDS pandemic more recently in the 1990s. If you recall, there was a lot of condescending interventions, assuming that the Africans are morally, particularly sexually incontinent in terms of sexual ethics. The only intervention they thought of was to send them condoms and more condoms and more condoms. Little attention was given to the fact that they could dig deep into their moral agency to devise interventions consistent with their culture, consistent with their moral agency as human persons. The second point I want to raise is that Africa is navigating COVID-19 at the intersection of what Paul Farmer calls pathologies of power. Shawnee talked about power and empowerment and communities that are powerless and others that have power. Those who do have power use it in pathological ways, like sick ways. Paul Farmer considers it an ethical imperative to bear prophetic witness to the atrocities and violence that the impoverished face. And many of those impoverished are Africans, whether they are in Africa or in Haiti or in Auckland. As a Catholic medical doctor, he suggests that we follow our Catholic ethical imperative to bear prophetic witness. And Shawnee has pointed out the importance of following through with the Catholic social teaching that calls us to name and shame those disparities and inequalities and so forth. And so the best kept secret in Catholic social thought and its principles of solidarity, principles of intrinsic worth of the person, is time to get them out of the closet and it's time to apply them. Paul Farmer also seems to agree with Bob that ill health and disease seems to follow the impoverished. And I say impoverished deliberately because the poor are not poor because they have a gene, a genetic predisposition to poverty. They have been impoverished by pathological application of power in their midst. And these pathologies of power include racism, sexism, and colonialism in Africa's case. They work cumulatively and multiplicatively to exacerbate the vulnerability of the poor to disease and allied issues. As the speakers before me have pointed out, a major pathology of power is anti-Black racism. This not only exacerbates poverty, vulnerability, poverty among the Black people, racism literally kills. And we have examples of that before COVID, after COVID, during COVID. Racism literally kills. It jeopardizes the very lives of Black people. Today, there was a report of yet another killing of a Black person. I think it was I forget where it was Nebraska or something. Police, just because of their color. Racism literally kills. And this year, there have been an outcry through the Black Lives Matter to consider how racism is deadly. It's lethal. It's not just makes people sick, it kills them. So we need, as ethicists, to name that reality. Due to racism in matters of healthcare, a phenomenon that has been named actually in the literature as medical apartheid, so Africans have not only been shortchanged, but have often been used as guinea pigs. I underline that. To test the efficacy of medicine and other interventions without the outcomes benefiting them. And this has precedence in the US, in the what I'm calling Navigating COVID-19, in the shadow of Tuskegee, the experiment that was done among Black people just because they were considered disposable as a rabbit in the lab, on which we can test all manner of chemicals that they will never use. The rabbits don't use cosmetics. That doesn't stop us from using them to test chemicals on the skin and then dispose them. There's a precedent of using Africans as for experiments, like they did in Tuskegee. And so my worry as we consider COVID-19 is how this Tuskegee effect might play itself yet again. There is evidence that it played itself out during the HIV/AIDS, using Africans as guinea pigs. The Tuskegee experiment looms large in my mind as I consider the interventions regarding immunizations that have not been tested here, but there's already talk of testing immunizations, and I fear that Africa will be used again. I'm responding to this whole question as an African theologian and ethicist. This is important to note that in the process of discerning the ethical issues, we do not do it as individuals in Africa. We have developed a method of discernment of theological issues and ethical issues as a collaborative event that aims at looking for solutions together, as in we are in this together. We are Africans together. We are not high in the universities and the poor are down there. We are in this together. We have developed, therefore, a method of discernment which we have called Paleva, and which results in what Father Roberto, the Jesuit par excellence, has called ethics brewed in an African pot. And so my hope is that in the event, in the case of HIV/AIDS, we will get together soon. This Paleva hasn't happened yet. We will get together soon and discern our way around this crisis, as we have done in the past. We already did 3 years of Paleva between 2013 and 2016 to discern what ails Africa and how the African church, as a people of God with a mandate to do something about it, what can be done. I also want to throw out there that, as was mentioned, I'm a founder member of the Circle of Concerned African Women Theologians, and we have done our theology and as ethics. We didn't call ourselves feminists, we called ourselves Circle of Concerned Women Theologians. And we commit to doing applied ethics, applied theology around issues of concern. In the 1990s, we focused on the HIV pandemic. Right now, we have a mandate going forward to focus on climate change as a matter of urgency, but we might pivot given the COVID-19 crisis to doing applied ethical research and publication around the issue of COVID-19. I also come to this presentation very much aware that I carry an invisible backpack of privileges, maybe invisible to me, but which I'm taking this opportunity to have a look inside and to see how this privilege, the question of privilege and power was raised earlier on. How does privilege, my privilege, shape my image, my imagination about the ethics of COVID-19? And as I reach I reached down my backpack of privileges. I note that one of the privileges is that I'm informed, I'm educated. Bob talked about education as a factor. I understand the facts and I can analyze the facts as they are presented to me, elusive as they are. So that privilege carries responsibility. Knowing what I know, do I get to be morally obliged to share that knowledge? Knowledge is power with those who are less privileged. I have a privilege in that I can easily comply with the mandates and recommendations for prophylactic action. The key recommendations is that you must shelter in place. Shelter in place. I have a privilege, I have a place to shelter in. I can stay indoors and be safe. But what about the millions? Many of them in Africa that don't have a place to live in, let alone wait out the duration of a pandemic like this one. I'm obliged as a Catholic and as an ethicist to raise that question. Who cares for those who have no place to shelter? I have the privilege of wearing a mask. I can afford a mask. For us, it may be like 50 cents, but for a family of 8, it may be in Kenya, they have to juggle 50 cents times 7 is a few dollars. How do we make a decision? Because a moral decision, do I buy food for my family or do I buy masks for my family? And I'm obliged as an ethicist to raise that question, affording the methods of sheltering ourselves. What about that washing hands? 20 seconds, they say, with flowing water. But as I have pointed out elsewhere, that's a luxury. It's a privilege that I have. It's a luxury that I have, but it's a luxury that thousands and millions, most of them in Africa, don't have, because in their place, water costs more. Even drinking water they don't have. It costs more than a bottle of Coke. And so those are the kind of prophetic applied ethics questions that I would be raising around COVID-19, because the whole question of privilege, and I'm privileged in that way, and I'm morally obliged to leverage my privilege so that I can raise those questions of concern. I want to say as I conclude, my invisible backpack also it has those tools, principles of Catholic social thought that Shawnee talked about, which have turned out to be the best kept secret. I need to out those, get them out of the closet. But in my backpack, I also find the principles of what has been called Ubuntu ethics. Ubuntu ethics. Shawnee talked about a culture of individualism, me, myself, and I. In contrast, Ubuntu ethics emphasizes in the Western development of ethical thought or rights and so forth, all those negative rights. The principle is, I think, therefore I am. But in the African context, the mantra has been proposed, we are, therefore I am. And so digging deep into the Ubuntu ethics, which I've also inherited, I wonder how that thought that we are in this together can truly be a springboard for constructing responses and interventions that not only take care of me, myself, and I, but also take care of my neighbor. Wearing the mask turns out to be as much as about protecting myself as protecting my neighbor. That is something I find in my African ethical toolkit. I also find there the fact that, contrary to the myth that Africans are are not capable of morality. Africans do in fact have a system of ethics. While the West has tended to go on the ethics of rights as entitlements, Africans have embraced a virtue ethics system, a virtue ethics, a system of virtue ethics. And my African colleagues and analysts, particularly one, two of them I'll mention here. One is a Catholic priest called Mosha, called Magesa, Laurenti Magesa, has written a whole book called African Religions, the Moral Traditions of Abundant Life, and made the case that if our ethics, our religion and ethics support abundance of life rather than subverting life. Much of the narrative says Africa's, Africa is full of poverty and all those kinds of things, but that's not blamable on lack of ethics. We do have a system that supports life and life in its abundance. Like Jesus said, I came so that they have life and have it abundantly. That is supported through African religions and ethics. In particular, I would like to quote my colleague, Sambuli Mosha, who has taken time, I didn't have that slide to show you the book, to analyze what the content of Ubuntu ethics. He identifies 6 virtues that are embedded in Ubuntu ethics. The first virtue is reverence, which resonates with the whole question of the dignity, inherent dignity of the human person. We are morally obliged to revere one another. This is more than respect, to revere one another. Reverence is a virtue. Self-control is a virtue. If COVID-19 has taught us anything, is the importance, not just like the casual self-control in terms of sitting still in the house when you feel like going to the bar, but self-control is an inner kind of predisposition that says, be still and reflect on what really matters. You have the virtue of silence, has been identified, and when I talk about this with my students, they're like, silence, a virtue? What about what happened to freedom of speech? And I try to explain the silence that Mosha is talking about is the silence that precedes speech. So that when you do speak, you truly speak. You're not just mouthing words. It's a silence that allows you to reflect and to hear the other, so that when you speak, you are responding to what they said rather than what you thought they said. There's also the virtue of courage that will be much necessary. Courage is not just sheer bravado. I'm going to go to that gathering and see, defying the orders to stay inside. That's not courage. Moral courage suggests that we are going to be able to point out, like we are called by Jesus himself, to point at those disparities and call for transformation of structures that facilitate disease, facilitate what Paul Farmer calls disease having a preferential option for the poor. We are called to diligence, and this is, and I might welcome suggestions about how this virtue of diligence might apply in this context, where only some workers are supposed to not only be diligent and courageous, but work in ways that threaten their own health, like the farm workers that have been named in recent emails that I have got, the farm workers those essential workers that produce our very food. Nobody is taking care of them. Last week, there was a caravan of volunteers taking food to the farm workers, to people who are hungry, despite the fact that they are the ones who are producing the food. And the essential workers in the retail are working diligently and with courage, but are we pushing them in the direction of loss of what Shawnee said? Work should not just be about hand to mouth. Neither should it be drudgery, as it's threatening to be under COVID-19. It should be a place of fulfillment. So diligence is a virtue. COVID-19 has revolutionized the way we work, the reason we work, and I think it's time to look again at the world of work and the rights and responsibilities. I think, as Bob said, the Catholic social thought, he cited the encyclical on labor. There's more in Catholic social teaching and in the African Ubuntu ethics that we can look to as we try to discern our way around the ethical ramifications of COVID-19. I want to conclude not with a negativity. It's been like, you know, what's lacking, what's missing. But amidst all these concerns, I have a sense of hope. And hope in itself, I think, in my view, following Paul Freire, is not the same as optimism. It is not just like, oh, things will work themselves out. Hope, active hope, is almost a virtue in itself. And I look for hope in the midst of all these reasons for us to despair. One sign of hope is a sense of the imperative of mutual care, which has also shown up. There have been very inspiring stories of people who have been inspired to share what they have with those who do not, both here and in Africa, in Kenya in particular. I remember one landlord, considering all this shelter-in-place stuff, waived rent for his clients and also put up a food pantry for them since they couldn't go out and look for food. And so, while I recognize there's power in naming the issues in the spirit of the prophetic traditions of Christian social thought, there is also power in embracing hope and in celebrating the solutions, however small. I thank the organizers of this conference itself because it speaks to this hope. We wouldn't have had this conversation were it not for the idea that Gonzaga thinks there's hope yet. It's not time to throw up our hands. So hope is a virtue, different from optimism. I want to leave us with this image that was captured in April at the beginning of the conference. I present it to you as an image exemplifying the vulnerability, particularly of women that are impoverished in Africa and elsewhere. It's an example. This is somebody who could not afford a mask, and yet she knows that the mandate is necessary. She needed to wear a mask to use a public transport. In Mombasa, there's a ferry. Mombasa is an island, and so she needed to go back home after spending the day in the city, but she couldn't ride the ferry without a mask. So she made one for herself and for her little girl. This was one of the most inspiring images that I have seen. And so I leave you with this image also as an image of the resilient hope that characterizes Africa, that has helped and hopefully will continue to help Africa navigate this wicked problem of HIV/AIDS. If I had more time, I would play you one of the ways they are dealing with the pressure cooker effect is the way they have always done through music and dance. And music for them is prayer. There's a Pan-African music dance that's going on throughout the continent. You go to Ghana, it's there. You go to Namibia, it's there. You go to Kenya, it's there. And they're praying that God be with us. Emmanuel. They're not necessarily Christians. The song and dance is called Jerusalem. And I'll leave that. I can probably send you a link later on, because that is a heart. It's been encouraging to me to see people are not just closing themselves in and indulging in despair. Thank you ever so much, Gonzaga, for the opportunity, and for the Flannery family for allowing and facilitating this important palaver on COVID-19. Hopefully, this is not going to be the last palaver, because we do not know too much about the epidemiology of this disease. It is still very elusive, and the more consultations we can have, the better, in my view. So thank you very, very much.
Thank you so much, Dr. Hinga. This is indeed a palaver. This is a collaborative event, and thanks so much for your participation in this opportunity for the rest of us to have a moment of intercultural dialogue and appreciate the ways in which Ubuntu ways of life would be deeply relevant for us. If I could bring back Dr. Lutz and Dr. Daniels-Sykes to visibility. Thank you both. We do have a number of questions, a very manageable number of questions. And so I wonder if we might just head straight to those. Are you folks able to see those questions there?
Do you want us?
I can read it out loud. That's
Okay.
fine. Yeah. So one attendee asks if there's any comment on the lack of access of migrants to health services. It seems to me, they say, that they live with the 5 phases of oppression that Dr. Daniels-Sykes mentions. So lack of access of migrants to health services, and if that's indicative of those 5 phases of oppression.
I can respond to that. Definitely, it's indicative of the 5 phases of oppression. I know that right now there's such tension, and Bob talked about this in terms of the Affordable Care Act and that being threatened. But we also have to be mindful of the works of agencies like maybe Catholic Charities or religious communities of men and women, parishes, that could also figure out creative ways. Maybe they are physicians and nurses and healthcare people within those facilities, those centers. And perhaps this is also a role for Catholic hospitals or private hospitals to do some thinking creatively. I know there's such overwhelmingness right now with trying to deal with the spread of COVID-19, but perhaps there's another creative way of outreaching to our brothers and sisters who are marginalized, our immigrants and people who can't find their way to churches or to hospitals, to reach out, to go out into the community and to offer those types of services.
Good. Thank you. Others?
Let me also comment on that and say, yes, there's a care deficit. In one of my classes, we talk about the care deficit, particularly in the global north. People have, including child care, including elderly care. When people are working and they have an elderly person to take care of, the tendency is to take them to nursing homes so that you can go and work yourself. And so guess who feels that care deficit? Is mainly immigrant workers, particularly the undocumented, because it's easy to work under the ladder for those. So when the COVID-19 first struck, I'm like, I remember it struck in nursing homes and so forth. And I was concerned about the thousands and thousands of immigrant women, mostly, who go to take care of those elderly people, either in their homes or in care homes. And so that's a very valid question. Who cares for the caregivers? Where are the PPEs for them? Do they even get to eat? You may go and feed your elderly person gourmet food, but do you get to eat yourself? And so that's a very, very important question for us to consider, and it's an ethical question to be sure. The farm workers that I spoke to about earlier, the caravans were taking food to them, leave alone masks and so forth, because they are working in the fields. Nobody cares so long as the food supply chain is working. Nobody cares whether they ate or did not eat, whether they have masks or they do not have masks. And so there is an organization here that kind of has steps out to intervene on behalf of the migrant workers in the farms. I don't know that we have a similar enterprise. Maybe Catholic charities might pick this one up to advocate for the caregivers. I have had the, I guess, the privilege, come to think about it, of interacting. Alas, I have had reason to go to the clinic, to the hospital once in a while since June. And I noticed the caregivers, the nurses, all of them, 90% are not American, are not from America, they are immigrant workers. And I have had conversations with them in which sometimes they have talked about being treated in racist ways. They show up to help somebody and they are accused of having an accent. You know, they are not smart. They have, you know, I can't understand what they are talking about. And so, yeah, that's an excellent question.
As we continue, I again would welcome the audience to feel free to post questions in the Q&A. We do have two questions right now that seem to be kind of trying to get at the big picture of Catholic social teaching and the ways in which it still seems to be hidden. It's the best kept secret, but not in a helpful way. One friend here asks, how can Catholic social teaching be maintained when there seems to be division within the episcopate clergy and laity themselves. Okay, so perhaps intra-Catholic dialogue needed there as to sort of what that social teaching actually requires of us, and when and how. But a longer question comes from somebody who's working in a Catholic parish. This person asks, I work in a Catholic parish and find that there is a rift between people who strongly support the pro-life movement as solely anti-abortion and those who embrace a broader vision that seeks to support all human life at all stages, thus approaching healthcare and economic disparities as equally important issues. So perhaps to all three of you, since all three of you spoke of Catholic social teaching, this person asks, do you see a way to depoliticize the support of Catholic social teaching so that its promotion could be more widely embraced? That's if you can answer or address that question, it's quite a good one.
Yeah, I can maybe start with some reflections that I've been thinking about this question for a long time. And one of the things that we need to be mindful about is what is going on in our larger ecclesial situation, especially with membership within the Catholic Church, for example. And we can look at it in terms of the secularization of society, that even as I teach undergrads here at my university, many of them have been marginalized from mainline religions, and hence they are more spiritual than religious. And so and these young people were born in the early 2000s. And so they really did not get, many of them did not get a sense of who God is, who's a transcendent, and how does that all work? I find myself, as a theologian, also being a catechist. And so I'm concerned that we have, and I use this phrase with my students, we have these nones, N-O-N-E-S, on the rise. And in our secularization of society, where we hear the phrase I'm more spiritual than religious, I think our conversations are getting lost in terms of what does it mean for me to be a child of God? What does it mean to me to be in relationship, that you are my brother and you are my sister, instead of the me, myself, and I ethos that predominates. And so I really think we need to have more conversations in terms of what does it mean that I am not my own atomized individual, that for sure I am part of me, but I also have some relationships with you. For example, when we think about parking, why is there money that has to go into the parking meters? And when it expires, if you're not there to put more money in or whatever, you're going to get a ticket. Well, even in our society, there is this notion of the common good, that we can share this parking meter, but you can only be able to park for a certain time unless you pay more money, right? And so otherwise you're going to be penalized. And so really what I'm thinking is our society does call us to share, even when we're at a four-way stop sign or stoplight. We need to go through those areas in our secular world to really show, how do we share? How do we share in the marketplace? The 6 feet distancing pieces, the need to wear face masks before you go into this. And I know Wisconsin is really huge, just in terms of you just can't go into public spaces without face masks. No ifs, ands, or buts about it. So to take those opportunities to have conversations to show that in essence, we do have to share. When it comes down to healthcare, we need to really focus on, is healthcare just for me? Or am I also recognizing that my brothers and sisters can see healthcare as a good? And yes, they need it. So I'll just stop there. I have something to say about the pro-life and consistent ethical life debate, but.
Yeah. Bob or Teresia, any comments on this question of kind of intra-Catholic disagreement or?
I acknowledge Shawnee's reference to the generational thing. It's a generation disconnect. generational disconnect. Some of us remember pre-Vatican II church. I do, because I was a kind of a toddler. And I recall also post-Vatican II, the change, the window of change. And to go back to Bob's whole idea of education, and go back to Shawnee's thought of catechism. Catechism used to be, the role of a catechist used to be just to transfer doctrine, you know, what Catholics think about God, what Catholics think about angels and the dead and so forth. But I would see here the possibilities, the opportunity for a new way of catechesis, particularly even as an academic, transformative education, transforming consciousness through our curriculum can become a new catechesis. So education for transformation becomes, for me, a method of bringing these sensibilities, you know, to the forefront of the consciousness, particularly to the young, who are some of them disillusioned with all the bickering and the lack of unity within the church, but around certain hot button issues and ignoring equally or more important hot button issues like climate change. So I understand the nuns who are like, I'm not good. But I also think there's an obligation to attend to their desire, deep desire to belong, to belong to community that cares, the church as community that cares. So through education, through the curriculum, we can devise a new catechesis for social change and social transformation. And that curriculum, the larger title of the book that I wish we use it in my class by Moshe, it's a study in African indigenous education system for formation of virtue and character. I don't know whether that answers that question. And I've been thinking about the encyclical Humane Vitae, which was, we did, I think in my humble view, we did a disservice, the faithful, quote unquote, did a disservice to this encyclical because we reduced life to prenatal life. And that is the only life we should care about. Not that we shouldn't care for it. Many are beginning to say maternal health, good food when you're pregnant, shapes the future of that pre-life. So it's relevant for me for that reason. But life should be supported, and whatever subverts life should be named and shamed, as Shawnee said, throughout the stages of an individual. The dignity and intrinsic value of human life goes beyond prenatal life. That's what I would say about that. And so the church is short on application of that pro-life agenda.
Speaking of encyclical letters, as we draw short on time at this point in our evening, let me try to wind things down a little bit by screen sharing here something from the encyclical letter by Pope Francis, his third, that was released just this month, Fratelli Tutti. And I direct our attention here because I think in a variety of ways, all of our speakers and maybe Teresia, with your focus upon Ubuntu, that Ubuntu really is a wonderful expression of perhaps what Catholic social teaching means by solidarity.
Mhm.
And how solidarity is reflective of the irrevocable human dignity, the individual human dignity of every person that is situated in community. Earlier this month, Pope Francis wrote in paragraph 35, almost a kind of prayer or a plaintive style of writing here. He says, God willing, after all this, we will think no longer in terms of them and those, but only us. If only this may prove not to be just another tragedy of history from which we learned nothing. If only we might keep in mind all those elderly persons who died for lack of respirators, partly as a result of the dismantling year after year of healthcare systems. If only this immense sorrow may not prove useless, but enable us to take a step forward towards a new style of life. If only we might rediscover once for all that we need one another, and that in this way our human family can experience a rebirth with all its faces, all its hands, all its voices, beyond the walls that we have erected. Fratelli Tutti, the new encyclical letter on fraternity and social friendship. That feels to me like a bird's eye view of some of the particulars, the granular discussion that the three of you have had this evening.
Can I just put my 2 cents in briefly about the pro-life, pro-birth discussion?
Please.
Okay, so I've been thinking about this a lot as a bioethicist, and I just want to thank Teresia for her input on this. When I think about the pro-life piece, I think about it in antagonistic ways with pro-abortion. So you have this dichotomy piece that's there. What I'm arguing and putting forth in my writing and my thinking is a change in nomenclature coming from a theological perspective. Looking at pro-life and adapting that nomenclature, that way of looking at life from conception to death. All right. So just extending it in terms of a consistent ethic of life ethos. And then we have those who are really focused on the most vulnerable in the womb. So instead of pro-life, pro-abortion dichotomy, pro-life, pro-birth, looking at it from that lens. So I just wanted to put that out in terms of some work that I'm doing in terms of looking at the history of Humanae Vitae and looking at nomenclature, which changes over time, all the time. And then we have this opportunity to really, really go in and look at what this all means. I think that's going to help balance out on a lot of ways and teaching and bring around social transformation and social justice and social equality. So that's where I am. And I just wanted to put that out there.
Yeah, thank you. Thank you. We will stay tuned to your work.
Mm-hmm.
Well, time being what it is and Zoom fatigue being what it is, and the generosity of our panelists being what it is. Thank you so much for your time this evening, for your preparation. This really does feel like a community, and so thank you very much. For those of us watching, please know that a recording has been made, and we will be posting this on the Flannery website, which you can find at the Department of Religious Studies here at Gonzaga University. Thank you so much. Have a great evening. Look after each other, and may we have many palavers in the future.
Palavers, indeed.
Palavers.
Thank you very much.
Thank you all.
Thank you, everybody.
Thank you, John.
Shawnee, great to see you.
Yes.
You're the image of resilience for me.
Yes,
Yes.
very beautiful. Thank
Knowing
you.
what I know.
Yeah,
Yeah.
very good.
Thank you so much.
Mm-hmm. All right.
Be well,
Thank you,
everyone.
Bob. And thank you. Who else was there?
John.
John.
Yes.
Where did John go? Thank you very much, John, for preparing us and for this opportunity.
You bet. You
Okay.
bet. Good to see
Good
you.
night, everybody.
Good night. Take care.
Okay, thank you.